Hello, everybody. I am Professor Antonio Gracco. I am Associate Professor in the University of Padova, and I'm the Director of the Postgraduate School of Orthodontics here in Italy. I was the President of the Italian Society of Dental Medicine, and Francesca Milano, who will be the other speaker of these webinars, was the President of the European Society of Dental Sleep Medicine. We both obtained some years ago also the diploma of the American Academy of Dental Sleep Medicine, so we are deeply involved in this field. Concerning these webinars, Dr. Milano and I have developed a series of 4 webinars specifically designed for dental professionals interested in management of sleep-related breathing disorders. And our goal is to provide you with the knowledge and clinical tools needed to become familiar with this rapid growing field and to understand also how to successfully manage patients who are affected by snoring and obstructive sleep apnea. And in addition, we will introduce a novel intraoral device that we have the opportunity to develop over the past 2 years in collaboration with Smartee. And we believe that this innovative solution has the potential to represent a significant advancement in the treatment of sleep disordered breathing, offering new opportunities for both clinicians and patients. So I will be leading the first 2 sections of the webinar series. The first one is Introduction to Sleep Medicine. The second one will be the role of dentist in sleep medicine, while Francesca will talk in the 3rd and 4th meeting that will be in September, October. The third one will be, the topic will be how to manage a mandibular advancement device, while the last one will be how to manage a patient with MAB over time. So concerning the first topic, Introduction to Sleep Medicine, I will deeply discuss with you about 2 main problems, 2 main disorders, who are snoring and sleep apnea, that are the 2 breathing disorder that we can manage as a dentist expert in dental sleep medicine. I would like to approach this kind of topics by asking a series of key questions and then providing evidence-based answers, supported also by the current scientific literature. And the first question I want to give to you is, why do humans exhibit this kind of predisposition? And so you all have to know that air passes through the nose and the mouth in ideal condition before reaching the lower respiratory tract. And this is the normal and ideal airflow. Our specific area of interest is the pharynx, which can be macroscopically divided into 3 distinct regions. The upper one, that is the nasopharynx, that is behind the nasal cavity. Then the middle one, that is the oropharynx, that is behind the tongue and the soft palate. And the lower one, that is behind the hyoid bone and the epiglottis, that is the hypopharynx. This anatomical classification is very important because the pharynx is the intermediate collapsible segment, because we have during night a physiological reduction in muscle tone. And this intermediate segment is between 2 rigid segments. The one above is the nose and the one below is the trachea. And in the lower respiratory tract, inside the thoracic cage where there are the lungs, we have the thoracic pump. This anatomical situation, this phenomenon, explains why when we fall asleep, the upper airway, as you can see here in this picture, the soft tissue here tends to collapse posteriorly, resulting in a reduction of the upper airway lumen and the increased resistance to airflow. It's quite interesting. This article examines the evolution of the pharyngeal tract during human evolution and proposes an hypothesis explaining the development of obstructive sleep apnea syndrome in modern humans. What we know is this: in all quadrupeds, a dog here, an infant here, and an ape here, a monkey, the tongue is entirely contained within the oral cavity, unlike humans. So as you can see here, in these animals, the oropharynx doesn't exist, and therefore the pharyngeal dilator muscles are not necessary. As you can see here in dogs, apes, and infant, all the tongue is into the mouth, and the soft palate is touching the epiglottis, and so it makes a closer wall in the posterior area of the mouth. While in humans, we have an open space here that can collapse during night when we go asleep. And that's a great advantage for us, because this is the anatomical reason why we can speak, we can talk, and the other animals cannot do this. But it's also the main problem why we have a big problem with sleep, and it is snoring and it is apnea that happens during the night. So in patients with normal anatomical structures, the upper airway remains adequately open, allowing the normal passage, the normal airflow during breathing. As you can see here, we have an open retropalatal region and an open retroglossal region that is in normal airway anatomy in ideal conditions. But we can also have situation when we can have a narrowing of the upper airway that is quite common in OSA patients who suffer from obstructive sleep apnea. This can result, for example, in the reduction of the space in the retropalatal area, because we can have an elongated soft palate. So instead of having a normal dimension of a normal length of the palate, in some patients we have a bigger and elongated soft palate, and it results in a constriction of the airflow tract in the upper position in the retropalatal area. But there are also some other conditions. For example, we can have a more inferior and posterior position of the hyoid bone here because of skeletal features, including, for example, mandibular retrognathia or a shorter mandibular or maxillary length. And in that situation, in the retroglossal area, we can have a narrowed space for the air. But there is also another anatomical condition that is quite, we often see in our patient, because the narrowing of the space can also result from an enlargement of the tongue, but also of the pharyngeal wall. And this is commonly due to fat deposition. As you can see here in these pictures, we have an increased tongue fat, an inferior hyoid bone position that is moving posteriorly and is closing the space for the air. And that's the same situation when the fat goes in the lateral walls of the lower tract of the pharynx. This is quite well explained in this beautiful article. It's a representative three-dimensional volumetric reconstruction of tongue that you can see here in red, and fat within the tongue, that is the yellow part, from a magnetic resonance images in a BMI-matched postmenopausal female patient with OSAL on the left side of the picture, and postmenopausal female control subject on the right. And what we can see that both of the patients are second-class skeletal pattern. They have some amount of fat in the lower part of the mandible. They are both obese patients because the BMI is more than 30 for this subject and also for this one. But on the left side, we have an apneic subject because it makes 60 events per hour. That means that 60 times every hour there is a closure of the air tract, and so there is an apnea event. While the control subject on the right side, even if he has structural anatomical similar characteristics, it doesn't have HOSA because it has less than 10 events per hour. And the main difference from these two subjects is concerning the tongue, because in the apneic, tongue is much larger and there is an increased tongue fat deposition throughout the apneic tongue. As you can see here, the amount of fat here is 42% as compared to the 24% in the non-apneic subject. So what's about the second question? What is snoring and what is obstructive sleep apnea? When we breathe, the air passing through the nose is conditioned before reaching the lower airways. And this physiological process allows air to reach the lungs in an appropriately conditioned state, having been humidified, warmed, and filtered by the upper airway. Because what happens is there is a disruption of the laminate airflow, and it becomes turbulent because of the presence of the turbinates into the nose. And this is the ideal condition, and more or less this is what happens. The laminate flow goes into the nasal cavity, it's broken by the turbinates, it becomes chaotic movement of air, and it is the great opportunity that we have to humidify, to warmer, and to purify the air before it comes and they enter into the lungs. But the reduction, as you can see here in this video, the reduction of the airway space that happens during snoring and during obstructive sleep apnea creates a turbulent airflow that causes the soft tissue to vibrate, as you can see here, producing the sound of snoring. So snoring results from the vibration, particularly of the soft palate, uvula, and pharyngeal walls. This is what happens every night in so many thousands of people. So let's discuss deeply about snoring. It is more than a noise. It's a signal of potential health risks, because snoring should be considered a warning sign, because it may progress to us, as you can see here, and it may contribute to the development of cardiovascular disease over time. This is another beautiful study. This is a relevant experimental study that was conducted in rabbits, and the researchers demonstrated that vibration induced by experimentally generated snoring caused endothelial dysfunction in the carotid arteries. And these vascular changes may predispose individuals to the development of carotid atherosclerosis. So snoring is not only a problem of noise, but it can also determine some important problems during years. And another thing that we all know is that snoring affects also other situations. For example, it impacts the sleep quality, and it affects the relationship, because many snoring patients seek treatment not because they are bothered by the snoring, but just because their husband or their wives can no longer tolerate sleeping in the same room. And this is so important because the American Academy of Sleep Medicine made a sleep prioritization survey last year in 2025. And the question was, do you ever do any of the following to adjust your sleep routine to accommodate a bad partner? And they made this survey in more than 2,000 adults. And the results are quite interesting, because almost 1/3 of the USA adults, they sleep in another bed in the same bedroom, or they sleep in another space just to accommodate a bad partner. And also 37%, so over 1/3 of the responders, go to bed at a different time than desired to accommodate a bad partner. And we also know that 48% of adult patients between 35 and 44 years old sleep in another bed or in another room. So it's absolutely an important problem that is also giving some big problem in the relationship between couples. This is a really funny video I want to show you, because this is a situation that occurs every night. So please look carefully at the facial expression of the lioness and of the lion. That's sure the situation that happens every night in most of our houses. And this is something that also affected me in the past. This is me. In the past, I used an acrylic resin mandibular advancement device every night. It was absolutely necessary if I wanted to sleep in the same bed with my wife. It proved highly effective in advancing the mandible and controlling snoring. But as a rigid appliance, it requires adequate thickness to maintain its structural integrity and durability over time. And as you can see here, this is the device in my mouth, and this is the advanced position I tolerate, and I decided to be good for me not to snore anymore during night. But for more than, I will say, a year now, I have been using a sleep aligner that we developed with Smartee company, which has proven to be absolutely extremely effective, but also very comfortable due to its minimal bulk. And the interesting thing that is, this is for sure the world's first clear aligner system that can be used for both orthodontics and obstructive sleep apnea patients. I will explain, Francesca will explain in the next webinar how you can use this system not only to treat OSA patient, but also to treat patient who has misaligned teeth. And this is the report of my home sleep apnea test before using the device. And as you can see here, in a scale from 0 to 20, my snoring severity was moderate, 9 point. The total snoring time for me was 45 minutes a night, and the percentage of snoring time was 12. Then I moved to the sleep aligner, that is the simulation of the starting position. And then we have the titration. So I go on every month for 1 millimeter ahead. And this is my therapeutic position, 3 millimeter over the starting position that was more or less an edge-to-edge incisor position. And as you can see here, we have lateral wings. In this situation, they are hook-shaped and the mandible is pushed forward. And so the appliance positioned the mandible 3 millimeter forward relative to its initial position. And this is the device in the mouth. This is the overjet, and this is my ideal treatment position. And this is the same analysis 2 nights after the first day I wear the sleep aligner. And you can see here that the gravity, the severity of the snoring was only 2%. And this is after 4 nights, and I had no more snoring. But clearly, these devices are highly effective in reducing snoring. However, certain conditions may worsen the clinical picture, such as, I don't know, common cold or an heavy evening meal, or alcohol consumption before bedtime. So all our patients should be aware of this limitation and understand that the effectiveness of treatment may vary under such circumstances. And the device we use has always the lateral wings, that is the system that is pushing the mandible forward. And we always ask Smartee company also to add buttons on the anterior area, because we want the patient use elastics, vertical elastics during night, because it's so important for us to maintain the perfect control of the mouth opening. And I want to share you also this article. It's quite interesting because it says that from the initial position, let's say this is edge to edge position, we can have the mandible that can be forwarded positioned, I don't know, 4 millimeter or also 9 millimeter from the starting position. But pay attention what happens every time the patient can open the mouth. Even if you have a 9 millimeter protrusion from the starting position, when he opens 5 millimeter, the mandible has a counterclockwise rotation, so it goes back of 1 millimeter. And if the patient open 8 millimeter, the mandible come back 2 millimeter. And if the patient is able to open 18 millimeters, the mandible come back 3 millimeter. So as the mouth opens, the mandible undergoes posterior rotation, leading to reduction in pharyngeal airway space and potentially compromising the efficacy of mud therapy. Another beautiful study is this one. And this study shows that an increase in vertical dimension may lead to reduction in pharyngeal airway space, particularly at the retrolingual level. As you can see here, this is the situation of the apnea, because the epiglottis and the lymphatic tissue in the base of the tongue is pushing the epiglottis back, and so it's closing the hypopharynx, and so the airflow is not passing anymore. This is the situation where there is an open space because the mandible is pushed forward by the mandibular advancing device. But when the patient has the mud device in his mouth, but is this opening the mouth, as you can see here, the airway space is closing another time. So opening the mandibles tends to induce a posterior and inferior rotation of the mandible. And this rotation may cause the tongue to move posteriorly, thereby reducing airway volume. Consequently, excessive thickness of oral appliance may diminish some of the benefits achieved through mandibular advancement. That is the main reason why we love to use a sleep aligner, because it's very, very thin. And the possibility of pushing the mandible forwards can be done. At this moment, we are testing two different devices. We're using two different devices with two different systems of pushing the mandible forwards that are posterior wings, hook-shaped, or with a vertical design. And as you can see in both the system, you can decide to add buttons for vertical elastics during night. So coming back to our second question, we talk about snoring, and what's about obstructive sleep apnea? So this is what happens every time there is an apnea. So as you can see here, sometimes during night there is a collapse of soft palate and of the tongue, and so the space is going to close. The airway is not passing anymore until there is a signal for the brain that is called arousal that makes contract another time the muscle of the pharynx, and then the space is opening another time. So the reopening of the airway following an apnea episode results usually in a loud snoring noise that usually is called gasping. You can use an endoscopic evaluation. The upper airway obstruction may occur at various levels of the pharynx, and with the so-called drug-induced sleep endoscopy performed under deep sedation to simulate natural sleep, this endoscopic evaluation allows us to directly visualize which is the site of the obstruction, as well also as the pattern and the degree of airway collapse. For example, here you can have a collapse behind the palate. You can have here the collapse in the area of the tonsil. As you can see here, biggest the tonsil are and more the airway is going to collapse. But you can have also a collapse in the retrolingual area, as you can see in the tongue base on the epiglottis, that then collapse and close the upper airway. And this is important because when we are using the MUD device in the mouth, the MUD is going to reposition the lower jaw forward, pulling the tongue forward and keep the airway open for normal breathing. From a physiological part, I would like to give some information about the respiratory mechanics. So when we do inspiration, we have an expansion of the thoracic cage. We have a flattening of the diaphragm. So we have a lung expansion, and it's going to generate negative intrathoracic pressure. And the negative intrathoracic pressure generates a suction force that draws air into the lungs, much like a vacuum cleaner, a vacuum effect. In normal condition, under normal physiological condition, pharyngeal muscle tone counteracts the negative intrathoracic pressure that usually is less 5 centimeters of water. And this helps to maintain an open upper airway. So we have a balance between the muscle tone of the pharynx and the negative pressure from the lungs. But sometimes you can have some predisposition and you have a loss of balance because you have a reduced muscle tone. That is what happens every night when we go sleep. And so to overcome the increased resistance caused by the collapsed tissue, intrathoracic negative pressure increases a lot. It's like it's the same thing that happens when you try to drink through a straw and then you pinch it, you squeeze it. If you want to drink water, you must apply more suction pressure to make the liquid flow through the narrowed section. That's the same thing that happens in our pharynx. And so more and more the reduced muscle tone you have, and then you can have an increased respiratory effort and more negative intrathoracic pressure. And as negative intrathoracic pressure increases, you can see here, the pharynx becomes more prone to collapse. And airway collapse may occur at different levels, as we saw before, and can present also with different patterns, including, for example, here, anteroposterior pattern, including lateral patterns or circumferential pattern. And when you have a total collapse, then you have an apnea. And so the air is not able to pass anymore through the pharynx. And so what we see here is then when pharyngeal obstruction occurs, airflow becomes restricted and also altered. And these changes can be detected on the airflow signals, as you can see here in the home sleep apnea testing, in the polygraphic examination, which demonstrate characteristic abnormalities in the respiratory flow pattern. As you can see here, if we examine what happens across different degrees of airflow limitation up to complete obstruction, as you can see in the right area of the slide, the graph demonstrates the progressive flattering of airflow curve, ultimately leading to a completely flattened tracing, a flat waveform, that is apnea. And this is what happens when you can treat it using the CPAP machine, because the CPAP works by pushing air into the airway at the positive pressure, generating sufficient force to overcome the airway resistance and keep the airway still open. And this is what we see when we do a polygraphic examination. The airflow, when the air passes through the pharynx, has a normal draw, but when it tends to collapse and we have a limitation, the drawings of the wave flow is changing. We can have snoring, but when we have apnea, as you can see, the wave is totally flattened and the air is not passing anymore in the pharynx region. Question number 3. What is the global impact of the problem? So you have to know that snoring is for sure a global health issue. We know that 1 out of 3 adults is worldwide affected by snoring. And we know that more or less 25% of adults snore regularly. That means that they snore more than 3 nights every week. So it's absolutely a very important problem. And if we consider obstructive sleep apnea, we know that 1 adult out of 7 has OSA. And we can say that more or less 33% of our adult patients suffer of moderate to severe OSAs. That means that they have more than 15 events every hours when they sleep. It's a lot. It means that if we are in our waiting room and we think that there are 20 adult patients in our waiting room, we know for sure that 8 of these 20 patients, so the 40% of these patients, are affected by regular snoring, and the 14% of these patients are affected by OSAs. And in Italy, but all over the world, this is the problem, because we have more or less 60 million of people in Italy. 24 million adults suffer of OSAs. 12 million suffer from moderate to severe OSAs, but the most important point is that we are able to diagnose only 4% of these patients, and we are able now to treat only 2% of these patients. And these are more or less the percentage all over the world. So this data confirm that the problem is enormous in terms of prevalence, but this data also indicate that the opportunities for treatment and patient care are exceptionally high, and therefore there are significant professional opportunities for dentists who wish to become involved in the diagnosis and management and treatment of sleep-related breathing disorder. Even because this is a multidisciplinary approach, a multidisciplinary treatment, and the physicians who are usually involved in this problem, in this disease, are the neurologists. The neurologist usually gives drug therapy, but also behavioral and lifestyle intervention for sleep disorders. Then we have the pulmonologist that gives the CPAP therapy. As you can see here, the CPAP therapy is not a nice device. We treat a lot of patients who tried the CPAP machine and they don't want to use it because they have to use it every night for all the night. It's not a nice device. It's bulky. It's not beautiful to see, and it's quite discomfortable. And the third physician that can treat this kind of patient is the otorhinolaryngologist, so the ENT surgeon that used blades, and so he made surgery about the area of the pharynx. But what we know in the literature, we know that the results of this surgery is quite good in the first months, but then quite half of this patient has some amount of rebutant effect. So it's not total effective as treatment. Why, as a dentist, expert in dental sleep medicine, we treat most of these patients with mud therapy. And as you can see here, it's only a device that you have to wear in the mouth. And so I have to say that dentists play absolutely a central role in osseous management by providing an effective, efficient, and patient-friendly treatment, because we can provide a treatment approach that is for sure simpler, is more practical, and it is easier for patient to manage, and also for us it is easy to manage. You have to know that in the evolution of a mandibular advancement device, the first generation of device was quite bulky and invasive. The second generation for sure was more compact and functional, and it works very good. But with the third generation MAD, that is the sleep aligner we're talking about, they are incredibly thin, extremely comfortable, and easy to manage for both the clinician and the patient. This was the first device. The Napa was a monoblock, and it has in the anterior part between the lips, there was a breathing tube. The second generation device that works really very good, for example, this device is 2 pieces mud, and you have in the lower part the wings, and in the upper one there is the titration piece of the device where there is embedded the screw, that is the screw that we usually use for rapid maxillary expansion. That is a good device, but is absolutely bulky. While the sleep aligner, as you can see here, is an innovative, and we can use absolutely for snoring, but we can have also the opportunity of having another device. It's called the Sleep Aligner Plus. And this innovative appliance combines sleep medicine and orthodontics in a single system. Because at night, the lateral wings configuration is used to manage sleep disordered breathing, whereas during the day, the traditional aligner functions as a standard orthodontic aligner to progressively align the dentition. So what we can do with Sleep Aligner Plus is to manage the misalignment, the disalignment of frontal area from cuspid to cuspid. And also, you have to know that we can use this device, the Sleep Aligner Plus, to move teeth, to counteract the disadvantaged movement of the teeth that can happen using the MUD device all the night for years. Because what we know from the literature, but we'll discuss in the next webinar, is that after some years, when you are pushing the mandible forward, you can have a change in the overjaw and overbite because of a different position of upper and lower incisors. So with the Sleep Aligner Plus, we can correct the disalignment of frontal teeth, but we can also counteract this effect, for example, protruding the upper incisor and lingual incline the lower incisor. For example, this is a patient with the Sleep Aligner Plus before treatment, during treatment, and at the end of the first phase before the refinement, when we aligned only the anterior teeth from cuspid to cuspid. As you can see here, the second plover remained misaligned. But the patient is using the traditional aligner during the day, so he's solving his misalignment. And during the night, he's using the device with wings and with hooks to manage the snoring and those problems. So coming back to the topics of the first meeting, introduction in sleep medicine, the other question is, why do we need to manage this disease? This is absolutely important. This is the thing that you have always to talk with your patient, because chronic exposure to recurrent nocturnal apnoic events can result in severe long-term health consequences and significantly increase the risk of systemic disease. For example, as you can see here, if you have an insufficient sleep or a sleep deprivation, that is what happens if you have an obstructive sleep apnea problem, you can have alteration in some hormones like lectin and ghrelin, and it gains then, it can increase appetite and promote weight gain for patient. But you can also an alteration in the utilization of glucose, and so most of our patients can develop a type 2 diabetes. And you can have also an hyperactivity of the sympathetic nervous system that can determine cardiovascular disease, vulnerability, and hypertension. That these are things that we see in most of our patients. And so the risk of obstructive sleep apnea in our patient is to have 4 times road traffic accident, 3 times cardiovascular disease, 2 times workplace accident because of daytime fatigue. And if we discuss about OSAS and mortality, we know that patients with OSAS have a reduced life expectancy compared with the general population. I will show just 2 articles, but are incredible articles, very interesting. This is a large cohort study which followed thousands of patients over a 12-year period, demonstrated a clear association between OSAS severity and survival rates, because patients with more severe obstructive sleep apnea showed significantly reduced survival premature mortality compared to those with less severe disease, as you can see here. But there's another study is this one. As you can see here, thousands of patients followed for 22 years. And the cancer-specific survival rates for patient who has no OSAS, so less than 5 events per hour, the survival rates is quite high. But when you are going deeply in a more problematic issue, patient who has more than 30 events, so they have a severe OSAS problem, so they have a 4-fold higher risk of cancer mortality. Another beautiful study that I always show to the colleagues is this one. In this study, tumor cells were implanted into mice that were divided into 2 groups. One group was allowed to sleep normally, so he has a continuous sleep, whereas the other group experienced fragmented sleep because the animals were repeatedly stimulated to remain awake. When the mice were later sacrificed and examined, the tumor, as you can see here, in the fragmented sleep group, the tumor were found to be significantly larger and more aggressive as compared to the mice who had the opportunity of having continuous sleep. So what we know is that fragmented sleep, that is the one you have when you suffer from OSAS, significantly accelerates tumor growth and increases also tumor burden. Another question, and it is the last part of the topic, is what screening methods can we use to detect this patient? We always do these things, and this is the things I suggest you have to do. First of all, use validated questionnaires. Then we do clinical examination. And the third part is instrumental assessment. Concerning the validated questionnaires, I suggest you to use 2. It's a simple tools that measure the daytime sleepiness, and it is able to identify excessive daytime sleepiness. It provides an indication of a person level of daytime sleepiness, and it might be related to sleep fragmentation. And another interesting questionnaire is so-called the stop bang questionnaires. It's an 8-item questionnaire, and it is able to identify individuals who are at risk for moderate to severe obstructive sleep apnea. And each single letter has a significant meanings. For example, S is for snoring, T is for tiredness, O is of obstructive apnea. And so if you have a total score that is more than 2, so you can suffer from intermediate risk or high risk of OSA. The second step is the clinical examination. That is what we do every day in our clinical practice. Especially it's important to evaluate whenever anatomical conditions are present that may contribute to upper airway collapse. We see and we measure the excessive body weight of the patient, because a lot of our patients are not obese patients, but we know for sure that subject we have a BMI that is more than 30, so the obese patient, the prevalence of OSA is 40%, while the severe obese patient who have a BMI that is more than 40, 90% of these patients suffer from OSAs. This is another interesting picture, photographs of sumo wrestlers who are resting in their area, that is the training stable. All of them, as you can see here, are using CPAP therapy. And so what we do in all our patients, we measure the neck circumference that should be less than 41 centimeter in female and less than 43 centimeter in male. And just because, if you can see here, this is the structure of the pharynx. If we have the same body enclosure and the normal soft tissue, normal fat, if we put it into the body enclosure, we have a normal airway size. But if you have an obese patient, so the soft tissue is bigger, and you want to enter this into the same body enclosure, for sure, the lumen of the airway is smaller and the pressure is higher. And that is because, as I told you before, you can have fat into the tongue, but you can have fat also in the pharyngeal lateral walls, and you can have things that we love tissue anatomy. For example, in all of our patients, we see if there is some problem in the nose. For example, from this radiographic, you can see that there is deflection of the septum. But we look also into the nasal cavity, the nostril. We can see here there is a deviation of the nasal septum. In this other patient, we can see that there is an hypertrophy of the lower turbinates. So you can see into the nose, you can see the radiographic examination. For example, here you can have a nasal obstruction that may, of course, reduce also the effectiveness of mandibular advancement device therapy. In this patient, we have a deviation of the septum. We have an it's called colcabulosa. It's a morphological deviation of the traditional anatomy of the median turbinates into the nose. And so, of course, in this situation, we send the patient to the surgeon, to the AN surgery, who can give pharmacological therapy, but he can do also surgery for this patient. For example, he can distract the turbinates and he can suck them. And so taking off the hypertrophic tissue, you can have a wide we do always this kind of picture in our patient because we want to see of the amount of the tongue tissue occupying the pharyngeal airway space. Because if you have a big tongue, of course, it is much easier that during night, because of the reduction of the muscle tone, it can collapse posteriorly. And another picture that we always use is this one, and it is used by us to to measure the tonsil grading, because you can have so big tonsils that can occupy all the oropharynx tract of the pharynx. This, for example, is a patient that we saw for orthodontic treatment. In this picture, we saw that this patient was, I think he was 14 years old. He had so big tonsil. We made an home sleep apnea polygraphic examination that revealed 24 episodes of apnea and hypopnea every hour. That is a very high number for an adolescent. And so we didn't treat for orthodontic reason, but we sent it to the surgeon who make the adenotonsillectomy procedures. And this is the month after where we saw the patient. We made another polygraphic examination that revealed that the problem was solved. And as you can see here also, how is the beautiful changes that you have, you can see in the soft tissue, in the soft palate. And other things that we check is if we have unfavorable craniofacial morphology. For example, we pay attention of the structure of the maxillary, because, for example, if we have a transverse maxillary deficiency, is frequently observed in nauseous patients. So if there is the opportunity, we do all what we can to make a wider upper arch. But there are also some other sagittal and vertical alteration of the craniofacial complex in osseous patient. For example, we can have a counterclockwise rotation of the mandible. We can have the mandible that is retruded. And so in that situation, we have a smaller space for the hair in the hypopharynx region. And that's the same situation when we have an increasing in the lower third of the facial height. And then we go to the last part of our clinical evaluation, is that the instrumental assessment. Because if we want to be sure of the problem, we need to do a polygraphic examination. And when we do the polygraphic examination, as you can see, we can have a lot of information. For example, in this patient, we have the normal airflow, and then we have an obstructive sleep apnea that is during a lot, because usually an obstructive sleep apnea starts when the airflow stops for 10 seconds. Here we have 58 seconds of stop of the airflow. And so during this apnea, there is no more snoring. There is a desaturation, blood oxygen desaturation, and then becomes the signal from the brain that is called arousal that makes the muscle contract another time. Then you have the gasping, so the snoring rumor, and then the nasal airflow that becomes another time fluent. And then you can have, of course, when the apnea terminates, a marked snoring sound, but it is accompanied by reopening of the upper airway, and then you have an increase, as you can see here, in oxygen saturation, but you have also a rise in both respiratory and heart rates. So, as you can see here in this video, when there is the complete obstruction, the airflow is not passing anymore, and so the wave is flat. There is an apnea. And at a certain point, the brain triggers an arousal response that increases the pharyngeal muscle activity, thereby reopening the upper airway, terminating the apneic event, as you can see here, and then restoring normal flow. And then the heart rate and the blood oxygen comes up another time. So what we can see is that the American Academy of Sleep Medicine gives some diagnostic criteria for osseous. I will not talk about this in this section because we have finished our time, but what we know is that the AHI classification by severity says that if you have less than 15 events, you have a mild severity of OSAS, while from 15 to 30 it's a moderate case, while more than 30 is a severe case of OSAS. And all these things are written in the summary of the polygraphic examination that we see in our patient. So Sharon, I finished this part. I want to thank you and all the attendees. And if you want, of course, I'm available for some questions, but also because we are going to see the second webinars in a month, I will be more than happy also to answer questions in the next webinar if people want to send to you some questions during the next weeks.
Okay, so thank you for your presentation, Professor Antonio Luigi. So I just want to check if now any questions from the audience, so maybe we can reply here. And if you don't have further questions, maybe you can also feel free to let us know, and then you can ask in the upcoming webinars.
Yeah, sure.
You can ask our question in the chat box, and we will check and reply you.
Yeah, sure. Yeah, what I can see in that the next webinar.
July 20th?
No, I'm saying that in the next meeting, we will go deeply in the rule of dentists. So what I told now, I will explain better which are the possible therapeutic options that we have and which are the advantages of limitation of our therapy, and we will discuss which are the advantages of the sleep aligner procedures for treating this patient.
So in the meanwhile, I also want to share something about sorry, just a moment. I want to share, I just want to, before we finish, I would like to quickly share something with you. So we will have our Smartee European Congress on September 18th to 19th in Malaga in Spain. So this is the page of our speakers, and this is our program. So if you guys would like to attend our webinar, our congress, you can click here to register. And it will be 2 days of lectures and clinical sharing, and also a nice chance to meet colleagues and enjoy Malacca.